Good evening, everyone. My name is Jen Nolan, and I'd like to welcome you to the third webinar in Arthritis and Osteoporosis Victoria's 2016 Musculoskeletal Health webinar series. Tonight's webinar will consider beliefs in the management of workers with musculoskeletal injuries. Before introducing our presenter for tonight, however, I just have a couple of housekeeping issues to run through. Firstly, if you have any technical difficulties during the webinar, please refer to the message box on your screen. You can type a message at any time that will be read by the webinar organiser at Redback Conferencing. If you are listening via the phone, you'll notice a small time delay between the audio and the screen. This is normal, so don't be concerned. Also, whilst our presenter will answer questions after the completion of his presentation, you can actually type questions for him at any time. Can I suggest that you don't leave your questions to the last minute, as we will aim to finish no later than 8 p.m. Australian Eastern Standard Time. I would also be very grateful to all participants if you could take a moment at the end of the webinar to complete the exit survey. It will barely take you 30 seconds to complete. Our presenter for tonight is Dr. Darren Beales. Darren is a Senior Research Fellow at Curtin University and Specialist Musculoskeletal Physiotherapist. His research interests include improving understanding of the biopsychosocial nature of pain disorders from a lifespan perspective and facilitating integration of this knowledge into clinical practice and public policy. He works as a consultant physiotherapist in the private, third-party and public domains. Without further ado, I'll hand proceedings over to Darren. Thanks very much, Darren.
Thanks, and yes, thanks for inviting me and thanks for tuning in. So just as a brief overview, certainly, I approach these things from the biopsychosocial model. Tonight we're talking mostly around beliefs as one aspect of that model, but fully aware that there's multiple things in a patient's presentation that need to be considered, not just beliefs. And also, particularly in terms of this work area, just remembering that there's this other kind of parallel thing around national, organisational and individual factors that really can influence outcome of work injuries massively. So that's just an overview of the picture. And to kind of give some basic guidance towards that, I kind of thought of these kind of overarching principles, and I've kind of made them up. That's why it says Darren's at the top. So one is that biopsychosocial model of that includes an understanding of contemporary pain science, the principle that work is good for your health, and also the clinical framework for the management of injured workers. So I have just provided a few references. So that first one is to do with models of care in the workers' comp area that particularly relate to the integration of biopsychosocial model into that space. So there's a few examples there for interested readers to follow up with. Work is good for your health. Again, a few references there related to that. And if anybody is not familiar with the clinical framework, a reference to the clinical framework. Certainly in WA, we've had some figures lately that certainly less than half of people are aware of that framework. So if you're not aware of it, you're not alone, and it's a really good resource in general, but particularly for the management of injured workers. And that has wide acknowledgement across Australia from multiple professional groups and bodies in terms of endorsing that. So we're talking about beliefs, and so just a reminder that that is under this psychosocial domain within the biopsychosocial model, commonly referred to as yellow flags, and beliefs really fit around the cognitive factors. And the falling blocks there are just, again, a reminder that if you just manage beliefs, you could be missing the picture and everything might fall down. So we need a broad approach based on the individual to cover the correct factors. So just beliefs in general. So this is an old definition from Wikipedia, but I haven't updated it because I like this version, but you will see a different definition on Wikipedia. But it's a psychological state in which an individual holds a conjecture or premise to be true. And beliefs very much shape the way that we interact with one another and also the way that we might interact with the world and our perceptions of the world. is an example. So I might say to you, or I might show you this picture, and one person might say, well, that's a brilliant piece of art, but the next person might say, well, no, that's just a mess that's left on the floor after some painting of a real picture's occurred. So your beliefs could very strongly influence how you relate to that picture in front of you. And just another example of that is the classic study, I guess, with red wine, and it's the same bottle with the same wine in two different bottles, one an expensive bottle of wine and one a cheap bottle of wine, and you pour the wine into the glass and the person enjoys the wine more that comes from the expensive bottle, even though it's just the same. Now, related to that is this study's been done with MRI scanning, and don't worry about the dots in the MRI scan there, but that's just to tell you that not only does the person think that, one glass of wine tastes better than the other, but there's actually biomarkers in the brain of that kind of process. So how does that kind of roll over to medicine? So this is an interesting study as a general example of that. So Crum took workers in the US at a number of hotel chains and split them into two groups. And half of them, they told them that, sat them down and gave them an education piece on that their work is good for their health, and told them how their work, is really healthy. All this physical activity is really good for you, stuff around that kind of theme. So then they monitored the two groups, those they'd educated and those they hadn't, over a few months. There was no change in behaviour of the workers, so they weren't doing more or less work, they were doing the same amount of work. But what they did find when they followed them up is that the ones that had had the education had a decreased resting heart rate, decreased resting blood pressure, decreased body fat across a number of measures like BMI and waist circumference. So it's a very interesting illustration of how beliefs and thoughts can influence the physiology of a person. The classic example of this, to another degree, is placebo, and this is just one example from a couple of years ago of placebo knee surgery, where they've done an exploratory arthroscope, and then on half of the participants said, yep, we'll do the surgery, and the other half come out and said, yep, we did the surgery, though they didn't really do anything. And there's red and blue lines there for pain and disability, and they're almost identical. So the placebo is a very powerful and known kind of aspect of belief. And there's a lot of research around beliefs in terms of, and placebo for that matter, in terms of the areas of the brain that it's involved with and the changes in brain function. So this is just a picture to say, okay, well, here's a few of the different areas of the brain that might be involved with beliefs or important in that area, and kind of a few references to that. But just to get that point across again, that beliefs, while it sounds like a psychological factor, is tied very much to physiological changes within the body. All right, so if we move then to beliefs and how they fit to a biomedical slant, and the interesting thing is always around scans, and this is just a reminder of the meaning of scans. So this graph is showing positive results, and it's not a clean cut, but basically this is different age groups from younger, where's my dot? So this is around 20, 25 through to older workers, older people. None of these have pain, and these are the changes on MRI scanning. So even here, I believe it's the 21%, that's disc herniation. So something that you'd feel that generally would perceive to be strongly associated with pain and disability. 21% of people that have never had pain in their life have herniated discs. So another thing that might be kind of related to beliefs, particularly when we're doing scans and then showing them to people and kind of trying to interpret that. So related to that is this study, which has taken people that have had a back injury and have had an early MRI or not had an early MRI, and pretty much broken that into two groups, those with radiculopathy and those without, which really kind of aligns to guidelines of practice in this area. So the guidelines might say if you have radicular pain, radiculopathy, an MRI would be appropriate. So essentially what they found is that those that had an early MRI compared to those that had not did worse at 1 year follow-up. And the same, it didn't matter whether the guidelines said they should have had the MRI or not, they still did worse. So if they had leg pain and had an MRI, they did worse than those that had a leg pain and didn't have an MRI. So it's a really interesting look at what other factors might underlie the development of pain and disability in these people, and beliefs could be a big factor around that, where what's found on the scan can influence the course of the disorder from some period of time. Just another example of that. So this is a nice one, the lumbar discectomy surgery. Half the patients, they showed a piece of the disc fragment that they'd taken out, the other half they didn't. And once again, those that had been shown the disc fragment did better than those that hadn't been shown it. And this really ties to society's beliefs around the biomedical model, and that there must be something wrong in their body to cause them pain and disability. And this is a systematic review by Sam Bunsley, and this was part of her PhD, but I think this is a nice quote. A biomedical explanation for chronic low back pain was critical for an individual to establish their pain as being a legitimate disability, which could then receive the support of family, workplace and welfare agencies, and the lack of a diagnostic label to explain their invisible pain meant participants in many studies felt at risk of not being believed. So while we know the validity of this purely biomedical model to explain pain and disability is not well supported by the literature, the patients that we're seeing, particularly in this workers' comp environment and work health, they want that kind of explanation. So that's a real challenge for clinicians. How do we take these people that have this grounded societal belief about a pathological and biomedical explanation for their pain when that might not be the case? And we know as researchers and clinicians, hopefully, that most of the time we can rule tissue damage out as a cause. Only 10% of the time really is that an issue. And most of the time we've got a non-specific diagnosis where nothing can be found on scans. So we know these other factors are far more related to pain and disability than tissue damage. And that's an important message to try and get over to a lot of these injured workers. Okay, so how does the injured worker kind of go through the system, and how might this relate to that? So this is a kind of working model. You can see I've got my overarching principles in there again, but beliefs may be different at different times within the claim. So we've just talked about societal beliefs around a biomedical model, so even this beliefs and situation pre-claim are going to be an issue. The circumstances immediately after a claim can have a powerful effect. So a great example of this is a worker who might have been complaining of a potential occupational health and safety issue that may or may not be true, but certainly in their mind at least it's true. Then they have this injury related to that, and that sets up a massively negative situation immediately and falls into a blame game because this occupational health and safety thing wasn't dealt with when I warned them. If they had I wouldn't have got injured. So that could have a massive effect straight away. And then certainly as they start to progress on through the process, the beliefs can really be changed and shaped, particularly by healthcare practitioners and experience with that kind of thing. When I get to talking about workers' comp, it can be very easily to get negative. So just some positive news. For most people, they travel through their system. That journey through the system is satisfactory for them and gets them back to work. And so this is just some stats from WorkCover WA figures from a few years ago now. There's national figures now, much more recently from a year or two ago, that kind of mirror this, that for most people, they're satisfied with the process and it gets them back to work. That mirrors return to work rate. So here's recent data from 2014. So pretty much across states, the National Comcare Scheme, and in New Zealand, we see that return to work rate is around, approaching 80%. But the problem is for the 20 that don't get better, and the potential meaning that that's an unsustainable load for the system, and certainly then identifying factors around there. So the people below that line, you know, it might not matter if you use a biomedical model, and it might be appropriate to, or even if it's not appropriate, it might not matter because they're going to get better anyway. It's this other 20% up here where it's much, much more likely that other factors like beliefs are going to be, you know, paramount to how they're progressing. Just a quick example of that pressure on the system, and that's the return to work rate from things like surgery. So, and certainly in the workers' comp arena, when people get down the track and they've got pain and they've been putting up with that and they can't work, and surgery is offered to them, it makes sense that, you know, if they're offered surgery that might help them, they're going to, you know, clutch onto that and have a go. But when we look at, you know, stats from surgery, particularly in workers' comp, and the outcome is not that great. So, you know, the return to pre-injury duties from this sample over a couple of years that Harris did was only 3%, and 90% had ongoing treatment and 70% had ongoing opioid use. So that's particularly related to fusion. The results are not much more impressive for other forms of lumbar surgery. So again, that's something that we need to be aware of, and you know, their beliefs around what treatment they need and how that outcome is going to be, you know, go. I just want to mention too that on top of the workers' comp figures may completely underestimate the amount of musculoskeletal kind of pain in the workforce. So we've looked at the RAIN cohort very recently. The RAIN cohort's a birth cohort from Perth. They've been followed since birth. They're turning about 25 now, so this data was collected a couple of years ago. But in a report for Safe Work Australia that we did, we compared the RAIN data to the national data. And so certainly in the RAIN data, 1% of people who were working and had pain had a workers' compensation claim, which is pretty similar to the national rate of workers' comp claims in 22-year-olds. Only 7% had reported that to their employer, and 20% commented aside from that they had work-related spinal pain. So what we see in workers' comp might just be the tip of the iceberg of a bigger problem that certainly impacts, and certainly this did impact spinal pain on work productivity, particularly around absenteeism in young workers. So we might need to, while we're talking about workers' comp, we need to consider these issues from a broader context. I've thrown this slide in there. Also, within that broad context, there's a lot of stakeholders in this system. So this is a nice slide, and I think this is one of the references that I alluded to earlier, just to get you thinking about the different stakeholders, because it's very easy, particularly as healthcare practitioners, to get stuck in our own zone in the workers' comp system, maybe touch on you know, the injured persons factors, and potentially forget about some of these other factors sometimes. And that brings us on to then thinking about healthcare practitioner and stakeholder beliefs. So we're talking about stakeholder beliefs here first, and there's good evidence around how stakeholder beliefs influence, or particularly healthcare practitioner beliefs influence their practice. So this is a systematic review from Darlow from a few years ago now, but basically has found that clinicians with a biomedical orientation in terms of their own belief system are more or less likely to follow kind of practice guidelines. And also clinicians that are more fear avoidant themselves and have higher fear avoidance beliefs are more inclined to sign people off for sick leave. So it's a really good illustration of how beliefs of the practitioner influence their own practice. Following on from that, another aspect of this is how practitioners might relate to one another or different stakeholders. So we've done a little bit of work on this, looking at how physiotherapists beliefs in terms of managing a claim or a situation might compare to the insurance workers. So we use these little scenarios like this one. So an injured worker has returned to full work duties, however, due to the injury, cannot return to their usual running program outside of work. Insurance-funded physiotherapy should continue to return the worker to the pre-injury function. So you could either agree with that statement, disagree, or not really know. So if we look at the figures on that, basically on the physiotherapist side, we've got 70 or 80% really of participants agreeing that physiotherapy should still be funded. On the insurer side, we can see it's an opposite pattern where we've got a good 55%, certainly the majority, do not support that. So we have a real different kind of view between the physiotherapists and the insurance workers in terms of what the worker's entitled to here. And it doesn't really matter if that's a right or wrong or who's right or wrong, but what matters here more is like if the injured worker is seeing their physiotherapist and the physiotherapist is saying, yeah, you should get more treatment for this, and the insurance worker is saying, no, you should not get more treatment for this, then we have a situation where there's conflict in advice, and that can be quite confusing for the patient. And also potentially a question around how that's going to proceed. And then the injured worker can be stuck in the middle of that and confused in terms of what do I do. Another scenario, an injured worker has a sedentary occupation, they're overweight and deconditioned prior to the injury, but it's affecting their recovery now. The an insurance-funded conditioning and weight loss program is appropriate for this worker. So once again, you could agree with this or disagree or not know. We could also change overweight and deconditioned prior to the injury to psychologically distressed and has depression prior to the injury and put in a mental health comorbidity rather than an overweight one. So in this situation, there was no clear pattern. Some of the physiotherapists agreed, some disagreed, and some of the insurance workers agreed and some disagreed, and some, 25% were in the middle, didn't know. So once again, this could be a real point of confusion if you're getting conflicting advice from a physiotherapist and insurance worker in terms of what their entitlements are. That could be tricky for them to navigate. And also, in this situation, it makes you kind of wonder where's the equity in management. So one patient in this scenario could get managed very, very differently, not depending on the evidence, but just depending on the beliefs of the physiotherapist and insurance worker. And that's a simplistic view of two practitioners. So what about the doctor? What about the medical specialist? What about the wife at home or the husband at home? What about the supervisors at work? And what about the, podiatrist? So all of a sudden we're getting a much more complex picture between how these interactions could become confusing. All right. So moving away from healthcare practitioner beliefs a little bit to workers' beliefs. So poorer beliefs, and this slide particularly relates to the back beliefs questionnaire, which looks at the future problems with back pain and the inevitability of back pain. And certainly multiple studies have shown that poorer beliefs on that questionnaire are related with increased levels of disability, increased work absenteeism, decreased work productivity, and decreased long-term outcomes. That is the basis of a classic study, and I haven't got the slide slipped in here, but the classic study done by Bookbinder that targeted beliefs with a mass media marketing campaign in Victoria, and New South Wales was used as the control state. They targeted these back pain beliefs, particularly around, having back pain doesn't mean you need to rest, you should stay active, various things. And basically found that with that there was a sustained long-term change in behaviour of people with back pain in Victoria versus New South Wales on these kind of measures, so particularly around the number of claims and also when a claim made was how long the claim lasted for. Interestingly, though, similar attempts to replicate that in Canada wasn't quite so successful, and there's a lot of reasons for that. But so changing beliefs even at that global level can be quite tricky and intricate. I pulled a quote here, and this is from this study by Kilgore, who's done 2 really good systematic reviews very recently in the workers' comp patients in the arena, and particularly these are qualitative studies. So I thought this was a nice quote around, that worker's perspective on that. So rather than rehabilitating workers efficiently and effectively, injured workers find the majority of the interactions are negative, and the system is fraught with delays and denials, which add insult to injury, especially for longer-term claimants. Many have complex and invisible injuries, but it just is a nice comment that kind of points to where the injured worker might be coming from. And so that was one of the themes picked up across multiple qualitative kind of studies. And a number of the concerns or beliefs that become entrenched in these people are in this here. So there's concerns around legitimacy, adversarial relationships, difficult to get a diagnosis, difficult assessing treatment, chronicity of the injury, psychosocial consequences, and it's an ongoing circle that can have a large impact on beliefs. This is just another nice diagram in terms of relating beliefs to other factors and just showing the complexity of it on an individual basis. So we can pull beliefs out of this or fit it into this kind of model here, but it all fits around the complex relationship of these in an individual kind of basis. And then also knowing that this fluctuates and changes, hour to hour, sometimes certainly day to day, week to week. So the beliefs can be very transient and reliant on other factors. My slide's a bit out of alignment there, but these are a couple of studies that have looked at some kind of key concepts or factors related to beliefs. So one's around the nature and cause of the disorder, beliefs around the future. So we talked about nature and cause with the biomedical model, the future course of the disorder, and that comes back to the back pain beliefs and the bookbinder study, the consequences and beliefs around consequences, and the need for a cure and control. And I think following here is just some examples of what patients might say regarding that. So on the nature and cause, very common theme is conflicting advice. And you ask them, do you know what's wrong? Tell me what's wrong with you. And they don't know after seeing 10, different practitioners. On the future course of the disorder, it's never going to go away. So becoming catastrophizing and those kind of things. Consequences of it. So people might stop exercising and doing their usual things for beliefs that it's causing damage or going to make them worse, when in fact we know exercise is one of the best things for back pain. And cure or control, recovery becomes unimaginable. So there's some kind of themes around beliefs and quotes that might relate to that. And it's a nice way to think of them, and we'll touch back on that in a minute. So changing beliefs is the next kind of part of the talk. So first up here, I'm talking about kind of stakeholder beliefs. So we've done some studies looking at changing stakeholder beliefs, and particularly healthcare practitioner beliefs, and others have done these studies as well, and particularly using a biopsychosocial kind of education framework to get people to understand that aspect of pain to try and change their beliefs and understanding. So look, this is just a graph that shows, we went to each state, did a kind of one-day workshop with physiotherapists. This is the back pain belief questionnaire. A change of 2 points on this scale is related to clinically significant changes in behaviour. So that kind of data comes from Bookbinder study. So in here we can see with education we can change their beliefs. Colleague of mine, Peter O'Sullivan, did the same thing in Europe, so England, Ireland and Germany. We see very similar kind of changes there. So we know that we can, with education, we can we can change health practitioner beliefs, and other people have done similar kind of things. It is not entirely clear from that research, though, how that affects practice behaviour. So that's kind of the next kind of step, or where we need more information, is like, yeah, we can change beliefs, but then how do we change the practitioner behaviour? And we'll talk a bit more of that as we go along here as well. So we've done another education like this time not for healthcare practitioners, but for insurance workers, so claims managers, many of these, and most of them not having a health background. And particularly did some education on identifying barriers from a biopsychosocial perspective, and just basic education around concepts and meaning of things within that kind of model. So this is another measure of beliefs, the HC pairs, and we can see it's dropped by 5 or 6 points here. So again, this is a meaningful belief that has been, change in beliefs has been matched with changes in behaviour in a positive manner. And that was sustained at follow-up kind of 3 months after. I could put the same graph up there using the back beliefs questionnaire, and we'd see the same kind of pattern. We tried to look at this in terms of behavioural change as well, which is very hard to measure, particularly in a small-ish kind of study like this one. Certainly not a long-term study. But we did ask them, did the education sessions result in a change in the way you manage claims? So we've got a bell curve here. So certainly for half the participants, you would say, well, yeah, it did. But the question is, we don't know whether that changed their behaviours in a good way. We don't know that everybody's behaviours needed to change. You know, someone who didn't change might have already been operating correctly. So, but there is some thought that these education can change self-assessed behaviour. In this situation, we were also able to look at injury management advisors that worked at this organisation and ask them just for their observations on any behavioural change in claims managers. And we had some really nice comments around that. So they a number of them commented on increased engagement of junior claims managers, increased recognition of barriers to recovery and return to work, increased offering of potential solutions. So rather coming to the IMAs with, I don't know what to do, they would come, flag this and say, okay, this is what I flagged, these might be some solutions, what do you think? So that was really, rather than being a passive kind of participant in the IMA interaction, much more active. And also improved monitoring of case progress. So a reasonably nice kind of number of practice behaviour changes, but again, the next step of that is like, well, did that change the outcomes? And that we don't know. Okay, what should you do with the injured workers? So here we've got, oh, well, I didn't get a chance to finish this slide, so that's quite embarrassing. But I wanted to put a slide here about some helpful and harmful messages. Now, at the moment, I'm involved with a kind of a review paper of models of care in the workers' comp arena that's going to be published towards the end of the year, and certainly that's focusing on these harmful and potentially helpful messages. So I'm going to refer everybody to wait for that article to get some more information on there, although I have later on more generally highlighted some areas where you might be able to find some of that information. So yes, ignore that slide, even though I spoke about it for quite a while. So one way to look at beliefs is screening tools. So in the workers' comp environment, the Orebro Musculoskeletal Pain Questionnaire is one of the best. There is an app. I was involved with the development of this, although I don't actually know if it can be accessed at the moment, so we might have to go with the questionnaire ones. And there's the long form and the short form. So that can be really useful. What we've found with that, though, and we've just had this study published in Manual Therapy. It's just been accepted, so it's not available just yet. But we looked at matching clinician self-rated or clinicians' rating of a patient versus the Orebro, and because there's really mixed understanding of this in the literature, where some people saying no, clinicians are no good at this, you have to do screening tools to understand their beliefs and psychosocial factors, and others saying no, clinicians can do it just as well, if not better. it seems that a key marking difference between that is the use of vignettes versus real patients, with the real patient ones tending to show that the clinicians are as good as the screening tools, with the one with vignettes potentially not as good. We used real patients in our study, and what we found is it differed quite dramatically across different domains. So, and it was in physiotherapists again, but physiotherapists were really good on things that's inherent in their training, like disability, and sleep and daily function, okay at depression and anxiety, and really poor, interestingly, at things like fear, which are, a key belief kind of construct. So we certainly advocate use of these questionnaires, but using the questionnaires to complement clinician practice. As a step further from that, we've done this study about trying to see how clinicians go about using these questionnaires, because the evidence would suggest that they don't. So we did this study where we, at 11 clinics, put in a process in when the compensable patients came into the practice. Part of their paperwork included the short form ORABRO. So they would do that. It was done. The clinician wouldn't have to do anything in terms of giving it to the patient. It was there, done. The clinician still had to score it, so we educated on that. We educated them on interpretation of the individual questions as well as the total score, and integrating that with their kind of practice thoughts. And then we looked at use 3 months later. So during this time, 360 new compensable patients came through these clinics. So we're talking about quite a few patients. So before, we asked them, do you use screening tools with compensable patients? And in from never, seldom, sometimes, frequently, always, certainly more down than not using them so much side of the equation. Where on the other side, never, seldom, sometimes, frequently, always. So this is 3 months later after we'd put it in place, and then a great uptake. So that's a nice way where we've been able to influence people towards that evidence-based approach of using screening tools. Once again, we don't know what run-on effect that had in terms of effectiveness of management, etc. like that, but it's a starting point. Interestingly, even though the ORABRO wasn't put in the private client's paperwork, we asked them the same thing. How often do you use it with private patients? So before the intervention, the same kind of thing, not very often. And with post-intervention, it's not a shift as dramatic as with the compensable patients, where we can see this dramatic shift. But here there is a shift. And I'm going to say that was statistically significant. I hope I'm not lying. But certainly there's a shift here. And we thought that was a real good indication of practice behaviour, because in this case, the clinicians must have given the questionnaires to the worker or the patient, because they weren't getting it in the bundle of paperwork. So questionnaires can help, but talking to the patient is just as good and better, potentially. So going back to some questions that might be helpful in this regard, go back to those four kind of concepts of belief. So the nature and cause. So a very important question to ask these people is, what do you feel the cause of your problem is? And this doesn't mean, because I was lifting up boxes at work. This is a question about, why do you still have pain, or why do you have pain, or what's causing your ongoing problem? And always interesting answers there. I guess most commonly they might sway to a biomedical understanding of the disorder, which may or may not actually be appropriate. Very, very frequently it'll be like, I don't know. And that's good, because sometimes that gives you a clean slate to work from. So there might be two kind of common responses there. What treatment or help do you think is required for your problem? So this is a really, really important question, because if this person comes to me with a sore neck and they think that manipulation of their neck is going to help them because something's out, and they have 3 years of neck pain and pain sensitivity with hyperalgesia, allodynia, well, manipulation is not going to be indicated for them. Or if they have radiculopathy of the neck, manipulation is not going to be indicated. So does what the patient wants me to do match with what probably is needed? And if you can't meet the patient's expectations, you're going to be starting off on the back foot. And if they have expectations that don't match what is needed, then there's going to need to be some work done to try and shift that before then providing that intervention. Otherwise, your chances of success are going to go way, way down. Consequence, what are the barriers stopping you from returning to work? So just getting some insight on the individual's perspective on that is really helpful. Future course, when do you think you'll be able to work again? Do you think you're going to get better? Expectations around future recovery are extremely powerful predictor of outcome in work injuries and injuries in general, and very much related to and focused around beliefs. And this is a reminder about expectations. So managing expectations could be very, very important in terms of managing these people and managing the beliefs around that. What do I do to manage this? So we've talked a bit about assessing it. Where do you go next? So I've got a few kind of general kind of thoughts and comments on this. For the worker, education is clearly a starting point. This can be where things are very difficult but very important and time-consuming, but the time needs to be taken to do it. And also, this really needs a team approach. So you need people with similar understanding giving the same messages and often repeatedly to maybe change somebody's beliefs. There is a thing called the backfire effect on beliefs. Now, this has been documented more in politics, but I'm sure the same thing is true in health, where if someone has a belief and you educate them with facts that belief is incorrect, that has a backfire effect and they retreat further back into their own belief system. So I can think of many patients sitting here now like that, and I'm sure you all can. So that could become a barrier in this education process. And expectations and reality and readiness to change. I wonder if I've got a readiness to change slide. Let me see. Yeah, later on. But expectation versus reality and that education piece about that is important. Readiness for change, now that I've brought it up, could be really important. It may be that this person's just not ready to change their beliefs. And now's not the right time. And some assessment of that needs to be made, because again, you could waste a lot of time and effort trying to change this person when they're not ready for it. 6 months' time, maybe they'll be ready. And often that can be the transition around a cure, a cause, wanting to know what the answer is from a biomedical perspective, to how do I cope with this, and getting them to cope and realise that they may need to change their career and becoming a coping and moving forward piece rather than finding an answer. Just some things that are helpful related to beliefs and things that we want to try and encourage. So building resilience, self-confidence, self-efficacy, motivation, having a sense of control, and really teaching people to problem solve. So any strategies that kind of fulfill that are going to be highly tied to beliefs and getting the person in a better belief system. The opposite of that, playing the blame game, is a big one, and that anger relates to that. Fear, anxiety, rumination, and worry. Worry is a type of fear, but it's much worse because it's never ending. Whereas fear might be translatory, so it might relate to an activity. Worry might go on all day, so that can have far more of effect and is not uncommon in injured workers. So strategies to dampen those things down, again, might rely on beliefs and be useful. Readiness for change we've talked about. So wanted to point you to a few kind of resources that might help in imparting that knowledge and kind of going on this belief space. It wasn't that easy to find a lot of stuff, but in Perth we have the Pain Health website that has a lot of information in general for chronic pain patients around understanding pain, understanding different aspects of management of pain. And there's a work section that's being rolled out soon related to that I've been involved with. I found this website, injuredworkerssupport.org.au. I can't remember anything about it now, but I did find it, so it's there. When I was searching, a lot of the kind of resource ones were lawyer based, and unfortunately, not to offend any lawyers out there, but there was no doubt that involvement of lawyers has a negative effect on their outcome. So I think we need to be a bit careful just sending people off willy-nilly, because if they go to those lawyer ones, it might not be the exact messages from a health perspective that they need. But there's certainly lots of resources like that from a legal and rights standpoint. But then, of course, the work cover authorities in each state provide that service pretty well, as far as I know. Also, on our website, painoptions.com, we're just developing this section called Essential Knowledge for Injured Workers. Now, I put the early content is available, and I didn't quite get it up today, but in the next few days, the start of that will be available. So we have topics like my scan does not dictate my outcome. So for education of beliefs around scans, we've got a piece around return to work is good for my health, and a one-page website, brief kind of descriptions around that for brief education and links to other resources. The one that I've just got to kind of finish tonight is pain does not equal damage. So one video of somebody with allodynia as a really clear example of where a stimulus that is not painful is interpreted as pain, but then just some information. So we're building these, so that's 3 that'll be up in the next few days, but over the next few weeks we'll add more. We've got about 9 or so that we want to add, so that will be completely free, so I'm not really plugging myself there, but we think it's a service that's not really out there at the moment, and actually my web kind of search aligned to that. And other resources for healthcare practitioners. So self-reflection is a key to understanding. So one of the biggest things we see is about knowing your limitations as a practitioner, and using that then. And self-reflection basically is like, I'm not strong in this area. A, I can upskill there, or B, I'm going to refer to somebody else that might have skills in that area. And I guess this is a comment very much for physios who are really good at referring on to other practitioners, but not necessarily, more experienced physiotherapists. But that may occur in other fields that I don't know so much about. But that's a really important part of the process, and certainly across, from the review of insurance data that I see. Hanging on to patients when your effectiveness of management has clearly stopped a long time ago, then that's where this kind of reflection process is useful. Just pulled out a few other resources there. So returntoworkmatters.org, fantastic resource for clinicians. Workers' comp authorities have some information. I've flagged 2 things here from Ivan Lynn. So one, his article on Aboriginal people, chronic low back pain, healthcare practitioner and communication. And this has a nice couple of tables that kind of talk about helpful practitioner communication with Aboriginal people and non-helpful, which aligns well to non-Aboriginal Australians as well. And this one that's a bit more readily available, because I've put the web link there, and that has that more generally, and again some of those helpful communication things and harmful communication things that I touched on earlier. That's an acknowledgement for some of the people I work with at Curtin University who are involved in a lot of the studies that I've just kind of talked about. All right, thank you. I'm done, and maybe there's some questions.
Darren, that was just such a comprehensive presentation. It was fantastic, so interesting, and lots of positive messages and lots of really good, straightforward things for health practitioners to use. A few issues of concern there, I guess, as well, with regards to, as you were saying, with the clinical framework. So many clinicians are not aware of the framework and certainly don't follow that. Just on the note with the framework, does it actually allude to the issue of sort of beliefs, expectations and so on at all, or is it very much about basically the clinical management?
It's now I'm really in trouble, Anna, because I can't remember the 5 principles offhand. But there's one of them is about measuring, using validated measures of outcome, and I'd put screening tools in there. So I think it does allude to that. It certainly alludes to a biopsychosocial model. It alludes, and that not alludes, that's like a key, principle of it. The other thing is about enhancing individuals', self-management and coping skills. So I think that all aligns beautifully with the framework. Yeah.
There's a question.
Yeah, and I think.
Go on, Darren.
No, go.
There's a question, do you have examples of how to assess readiness for change without alarming patients that you sense their hesitancy to treatment? Yeah,
look, it's an interesting thing. I'm pretty sure there must be questionnaires out there. I haven't looked for them myself, so I can't directly answer that. And it can be something, because you may not want to get you've got to do things to get the worker on side, and broaching that might get them off side, and that might not be helpful in the first instance. So I think that may be where that kind of question's coming from. But in the end, like my colleague, I was telling you, I work with Tim here, he's really good at this because, but we do a lot of one-off reviews, which makes it a bit easier, where you can be you can tell pretty quickly, particularly when there's a lawyer involved, that there's, there's a paradox where they're coming for treatment to try and get better, but they're actually being told, the less capacity you have, potentially, the more better you're going to go in court. So using that, not directly, but saying, well, are you seeing a lawyer? Because that can be a big barrier in this area. What's the lawyer telling you? And then using self-reflection. So if the lawyer's telling you that and you're here to do this, does that match up to you? And then getting them to self-reflect on it is a good idea. And I think that question about, do you think you're going to get better, or do you see yourself working in 3 months, is really a massively good question about that as well. Yep. And look, it might not be that you completely cease your involvement, but it might be like, okay, look, those strategies aren't going to work, but look, this person's also depressed, not exercising, so I need to give them some general exercise and monitor them in that way, but I need to be upfront and communicate that with other people so they know that that's what my plan is, and I'm not, doing needless treatment.
Darren, if obviously a multifocal approach with regards to education, with regards to health practitioners and people working within the sort of compensation industry and so on is important, would you sort of see one group as if you had a certain initiative, would you preface or prioritise one over the other with regards to health practitioners are the first area where the education is needed, or those involved within the compensation system, or just several groups really would benefit from the education you spoke of?
Yeah, I think it's multifaceted. I think one of the biggest barriers to return to work is the workplace and the direct supervisor. So if I actually had to pick one, I would say direct supervisors. But yeah, I think, across the board with all stakeholders, there's value to it. I think the answer to it, and this can be time consuming, but it is to pick up the phone and talk to these other people. Now, in WA, you can bill for time on the phone and communication time. So it shouldn't be a barrier from a financial perspective, even though people say that it is. Now, I don't know if that's the same in other states, and I don't believe it is. But I think if there's an instance where, something's not right, picking up the phone can be a good kind of initial phase of that. But I think in general, education's needed across the board. I guess the other thing I would say is you can often preach to the converted. So how do you get to the people that aren't following the guidelines? And that can be impossible. So we need to start at university level education with some of this stuff and get it ingrained there because it's, work on that generation, because we've probably missed the boat on the other ones.
Okay, well, let's hope there's some hope for the future then, maybe.
Oh, yeah, absolutely.
Yeah. Well, listen, on that note, Darren, we might finish there. There's no further questions, which I'm not surprised. It's really, you've covered so much in your presentation. It's been really wonderful and providing lots of food for thought. So, look, thanks again, Darren, to you. Thanks for people who have joined the webinar tonight. Could I ask you to just take a moment to complete the exit survey, which will come up on your screens just after the webinar closes. So, Darren, thanks again for a really fascinating and comprehensive presentation. And good night, everyone.